Everyone, my name is Megan O'Rourke and I'm the Associate Director of Regional Programs for the Office of Alumni Relations at USD. I'm also a proud member of the class of 2015. We are happy to have you for today's event, Vaccine Hesitancy, What It Is and Why It Matters. Today's program is brought to you by the USD Hahn School of Nursing and Health Sciences and the Minneapolis Torero Club. Before we begin, we would like to extend our thoughts and prayers to the Minneapolis health community who were affected by the shooting at the Alumni Health Clinic today. As you can see, with what is going on in the world, especially with the emergence of the COVID-19 pandemic, now more than ever is the topic of vaccine hesitancy in the forefront of many people's minds. So we have a lively discussion for you today, so let's get to it. At this time, I would like to introduce Christina Bergstad, class of 2008, Minneapolis St. Paul Torero Club president, to briefly talk about the club and all the great things that they've been doing this year.
Thank you, Megan. Hi, everyone. I am Christina Bergstad. I am the president of the Twin Cities Torero Club here in Minnesota. And since the pandemic started, we have been doing a variety of different virtual events, and we are excited to partner with the Hahn School of Nursing and the Health Sciences tonight and have some conversations that are important and informative, and especially features Dr. Ferris, who works here in Minneapolis and can speak directly to the Torero community here in Minnesota. So at this time, I would like to introduce the moderator of tonight's event, Dr. Eileen Fry-Bowers. Dr. Fry-Bowers is an associate professor at the Hahn School of Nursing and Health Sciences, associate provost for research administration, and chair of the USD Institutional Review Board. Dr. Fry-Bowers, the floor is yours.
Thank you so much, Christina. I'm just going to go ahead and share my screen. Okay, I hope that you all can see that. If not, if somebody could let me know. Welcome to the first night of our two-night event, Vaccine Hesitancy, a topic of special relevance as we begin the broad use of vaccines as a tool in our fight against the COVID-19 pandemic. And we work to change the conversation from vaccine hesitancy to vaccine confidence. Thank you for joining us for these very important conversations. Tonight, we're going to try to answer the questions, what is vaccine hesitancy and why does it matter? Join us again tomorrow night for a discussion on addressing the concerns of special populations. Tonight, I'm very pleased to be joined by my colleagues, Dr. Catherine Ferris and Miss Olivia Ball. Dr. Ferris earned her PhD from the USD Hahn School of Nursing in 2017. She is a nurse scientist whose doctoral dissertation centered on vaccine hesitancy. Her research focus is on social and ecological factors influencing parental barriers to childhood immunizations. In tonight's presentation, she will address how these social and ecological factors impede vaccine confidence. Ms. Ball is an RN who specializes in psychiatric mental health across the lifespan. She will be completing the Psychiatric Mental Health Doctor of Nursing Practice program at USD this spring. For her capstone project, she focused on using the psychotherapeutic approach of motivational interviewing to address vaccine hesitancy. In this presentation, Ms. Ball will explore how to promote vaccine confidence through a psychological lens. She will discuss topics including major influences on vaccine hesitancy and how discourse matters in nurturing vaccine confidence. It was slightly more than a year ago that we were introduced to the novel coronavirus SARS-CoV-2, otherwise known as COVID-19. Since our focus tonight is that of vaccines, I want to call your attention to two important dates last year that were pivotal in the vaccine development process. On January 12, 2020, China publicly shared the genetic sequence of COVID-19, which provided the opportunity from scientists around the globe to collaborate and share information to guide public health and research decision-making during this crisis. Importantly, once the genetic code was known, scientists began earnest efforts to defeat the virus. On January 25th, 2020, BioNTech entered the genetic code for the spike protein of the virus into its mRNA software, initiating the development of the first vaccine candidates. The toll of this pandemic has been and remains high. As of February 8th, there have been nearly 106.4 million cases of COVID-19 worldwide, with about 2.3 million deaths. Over 27 million of these cases have been in the US, with over 464,000 deaths. Broadly, there are disproportionately higher rates of COVID-19 illness and death in Black, Latinx, Native, and Indigenous communities. Additional data suggests that small ethnic populations, including Pacific Islanders, Cambodians, Filipinos, and Koreans, may also have higher than average COVID-19 infection and death rates. In addition, more than 29,000 US healthcare workers have died in the COVID-19 pandemic since March 2020, with the majority of victims under the age of 60, and again, people of color account for 65% of those deaths. Vaccines represent a new and effective tool in fighting the pandemic, yet recent polls show that anywhere from 30 to 49% of all Americans say they do not intend to receive the COVID-19 vaccine. According to a Kaiser Family Foundation poll, 33% of white respondents said that they would either probably not or definitely not take the vaccine, and the rates were higher for Hispanics at 37% and Blacks at 49%. The Centers for Disease Control estimates that 70 to 85% of all Americans must be vaccinated in order to achieve herd immunity. At present, 2 vaccines, highlighted here in red, have been authorized for use by the US by the Food and Drug Administration. These are the Pfizer-BioNTech and Moderna vaccines, both of which require 2 injections spaced either 21 or 28 days apart. On February 4th, Johnson & Johnson submitted an application for the emergency use authorization for its vaccine, which is highlighted in blue, which will require only 1 dose. AstraZeneca, already approved for use in the UK, and Novavax are currently conducting phase 3 clinical trials, and we are likely to see applications for the use of these vaccines in the US in coming months. There are other vaccines also in use in China and Russia. The Pfizer and Moderna vaccines have generated a lot of interest and perhaps hesitancy, notably for their new approach to fighting infectious disease. Actually, researchers have been working with the concept of mRNA vaccines for nearly 3 decades, and people have been given mRNA vaccines in clinical trials for other diseases like cancer, Ebola, Zika, and influenza. Messenger RNA is a sequence of genetic code. Essentially, it's a list of instructions that tells a cell what proteins to build so it can function. COVID-19 mRNA vaccines use a synthetic or man-made version of the virus's mRNA, which is wrapped in a lipid fat nanoparticle, and it tells our cells to make a harmless piece of the spike protein, which is found on the surface of the virus. You may recall that it's the spike protein that gives the virus its bumpy, crowny appearance and the name. Once our cells use this information, our cells break down the synthetic mRNA and get rid of it. There is no risk of acquiring the infection from a vaccine. The mRNA never enters the nucleus of the cell, which is where our DNA is stored. Next, the cell displays the spike protein piece on its surface, and this triggers a reaction in our immune system that tells us that the protein isn't there, it doesn't belong there, that it's foreign, and we build an immune response, much like what would happen if we had a natural infection against COVID-19. With the Pfizer and Moderna vaccines, 2 doses are required, which is not uncommon for vaccines generally. The first dose exposes the immune system to the foreign protein, which is called an antigen, and the second dose activates memory cells so that your body will remember how to respond if you are infected with COVID-19. Because mRNA uses synthetic material, these vaccines can be developed in a laboratory using readily available materials, which means the process for making them is quicker than previous other methods of making vaccines, which requires the cultivation of large amounts of virus. Given the current public health emergency and the importance of making vaccines available as soon as possible, The FDA is using emergency use authorization to allow the use of the vaccines. The vaccines have still undergone the same process of clinical trials required for all therapeutics to determine safety and effectiveness. Governments and private enterprise have expended extensive monetary and human capital on the COVID vaccine development, resources not typically available for this kind of work, which allowed the vaccine development process to take place in record time. Thousands of scientists have contributed to the science of the current vaccines. Hundreds have reviewed the data. 3 independent advisory boards in the US have approved their use, as have boards in the United Kingdom and Canada. Notably, when it comes to vaccines, adverse effects generally occur within minutes to hours after administration, sometimes days, but rarely at a week or more. Participants in the vaccine trials were followed for a minimum of 2 months prior to the emergency use authorization and continue to be followed. Existing and expanded vaccine monitoring systems at the CDC and the FDA continue to review data to ensure vaccine safety and effectiveness. Although the daily number of new cases of COVID-19 in the US has leveled off, we are faced with the emergence of new variants of the virus that causes COVID-19. According to the CDC, these variants seem to spread more easily and more quickly than other variants, which may lead to more cases of COVID-19. And an increase in the number of cases will further strain our healthcare resources, lead to more hospitalizations, and potentially more deaths. So far, studies suggest that antibodies generated through the vaccines with the currently authorized vaccines recognize these variants. Importantly, according to Dr. Fauci, the best way to prevent the evolution of mutations is to suppress the replication of the virus in the community, which means that we need to vaccinate as many people as quickly as we possibly can and as efficiently as we possibly can. As of Sunday, February 7th, the US has administered about 41.2 million doses of COVID-19 vaccine and distributed just over 59 million doses. In order to reach the point where 70% of the population is vaccinated, which is the bare minimum needed for herd immunity, and assuming 2 doses per person, for us to return to life as we know it, we need to administer, on average, 2.4 million doses of vaccine per day to reach this goal by July 4th, or an average of 1.9 million doses of vaccine per day to reach this goal by Labor Day, or an average of 1.2 million doses of vaccine per day to reach the goal by January 1st, 2022. At present, the US is averaging about 1.4 million doses of vaccine per day. So now I turn to our speakers tonight and I ask, how do we move from vaccine hesitancy to vaccine confidence so we can return to life as normal? Let's begin with Dr. Ferris.
Hello, everyone. I'm going to share my screen here first. Get this going, share. And okay, so thank you, Dr. Fry-Bowers, for that quick overview of the COVID-19 disease and the COVID-19 vaccines, and giving us a little bit background of what we have to do to thwart this vaccine hesitancy, which I'm about to talk about. I'm about to talk to you all about. It's an honor to have this opportunity to come and share with you some of the vaccine hesitancy through the lens of the socio-ecological model, and through the lens of the SAGE working group on vaccine hesitancy, determinants of vaccine hesitancy. So my objectives are to do a quick talk and review, define vaccine hesitancy, and then a brief overview of some determinants of vaccine hesitancy. I'll share some insight in clinical and research experiences that I hope will help you better understand the many complex layers of determinants of vaccine hesitancy that your family members, healthcare colleagues, neighbors, community members, and fellow Americans may encounter when making the decision to vaccinate themselves or others with any vaccine but most importantly, during this global pandemic, one of the many so far EUA approved COVID-19 vaccines. I have one disclosure. I recently received the Moderna COVID-19 mRNA vaccine on February 2nd, and I look forward to 6 weeks from that date to be able to vaccinate as many people in my community as I can, as I am as a nurse volunteer for the Ramsey County, Minnesota Medical Reserve Corps. With that, let's go on. So this is a quote from Madame Curie that I think she's a notable chemist and physicist and the first female Nobel Prize winner. She's the first and only woman to win a Nobel Prize twice too, and the only person to win a Nobel Prize for 2 scientific fields. Dr. Mike Osterholm in his SIDREP podcast that he does weekly highlighted this quote, and it resonated with me as well before I started this talk to complete this talk about vaccine hesitancy. In the context of all humans, we have to try to better understand the science behind the global pandemic of novel SARS-CoV-2 virus and the disease that it causes, COVID-19. Nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less. I dedicated my dissertation research to children vulnerable to vaccine preventable diseases and to research that would examine ways to keep children from ever suffering from a vaccine preventable illness. Now is the time and the opportunity for all of us, me and my colleagues here at UST, to share and help others to understand the many determinants of vaccine hesitancy, so we can target our conversations and interventions with those who are vaccine hesitant, to help them better understand this terrible disease, so that we may all fear less about a world where people will not accept a COVID-19 vaccine when it is their turn to get one. Thank you for listening. Oops. Sorry. So let me begin with the definition for vaccine hesitancy. It's certainly a delay in acceptance or refusal of vaccines despite the availability of vaccine services. It's complex and it's context specific, and it varies over time, place, and even with different vaccines. This is the fact that it's influenced by many contextual factors, individual being maybe a fear of needles or a fear of painful injections, group influences, a very concerning mistrust right now between communities of color and public health officials, likely due to historical racism in healthcare treatment of Black Americans and Latinx populations. On day 2 of this webinar, Dr. Ford and Dr. Collier will help provide us with some insight on the challenges that these communities face surrounding vaccine hesitancy. Next, here's just a short timeline of historic timeline, just giving you some perspective of vaccines and how they've worked to save lives over the years. And including including our BioNTech and Moderna EUA vaccines. Over a century of vaccines have led to a path for a healthier nation. This is immunizations are one of the most effective public health interventions of all time. They're estimated to have decreased morbidity by 92 to 100% for these vaccine preventable diseases. However, the success of immunizations comes with a decreased visibility of the morbidity and mortality of the illnesses that they cause, and consequently can lead some people to question the necessity, validity, and safety of vaccines, and to be therefore described as vaccine hesitant. Just who are these vaccine hesitant people? They can be individuals, they can be communities. I'm certain everyone in this webinar, attending this webinar, can tell me a story about an individual or community of people who are known to be vaccine hesitant for some or all vaccines. There can be family members, neighbors, community members, coworkers, healthcare colleagues, actors, and even politicians. vaccine hesitancy, like COVID-19, knows no boundaries. It can show up anywhere, any place, at any time. In recent history, vaccine hesitant parents refused to vaccinate their children with the MMR vaccine, or the measles, mumps, rubella vaccine. And because of this, studies showed pockets of intentionally unvaccinated children were linked to several measles outbreaks. Something to consider about when we're embarking on this COVID vaccine. In 2015, a measles outbreak linked to a California Disneyland theme park revealed that of the eligible unvaccinated measles cases, 76% were intentionally unvaccinated. In 2017, in Minnesota, a measles outbreak, 85% of measles cases were found in an intentionally unvaccinated US-born children of Somali descent. Interestingly, the 2017 measles outbreak came on the heels of a 2004 92% immunization rate for the first dose of MMR vaccine in the US-born children of Somali descent. And then all of a sudden, in 2008, it plummeted to 42%, and then resulting in 2017 in the outbreak. During the same time span that the Somali community had the plummeting of immunization doses, the non-Somali MMR1 dose immunization rates were at 88 to 89% consistently. What was the determining factor for vaccine hesitancy or complete refusal? I'll get to this a little bit later. Vaccine hesitant individuals and communities are described in the literature as being on a continuum of vaccine hesitancy, ranging from accepting some vaccines to delaying some vaccines and refusing some vaccines to complete refusal of vaccines. Let's take a look at some of the determinants of vaccine hesitancy through the lens, like I said, of the socio-ecological model and the SAGE working group on vaccine hesitancy. So my research examines social ecological factors associated with parental childhood immunization practices. This is the socio-ecological model that argues that individual behavior is shaped by factors at multiple levels, as depicted in this adapted figure. Most of the SAGE working group determinants of vaccine hesitancy overlap with the varying levels of factors for vaccine hesitancy depicted in the adapted SEM model. The SAGE working group on vaccine hesitancy talks about diagnosing the root or determinants of vaccine hesitancy in each specific setting, or for purposes of this webinar, and each SEM level. And we had looked to this as a fundamental to the development of appropriate and targeted interventions to encourage vaccine acceptance. Let's take a look at each determinants at each level. So at the interpersonal level, this is the level where we the vaccine knowledge that a person has, their behaviors, attitudes, whether they consider vaccines important, and any concerns they have about them, and then their knowledge of where they need to go to get vaccines. Do they have a trust in the health system, their providers, and the way a government handles the pandemic? Perceptions of the risk of COVID-19 and presence in a priority group for vaccination with COVID-19. We might have a little muckety muck here in that some people that have had COVID-19 may be vaccine hesitant, thinking that I have enough immunity, so I shouldn't get it again. But that's a little bit of their lack of personal health, maybe literacy about how the COVID, and because we don't know really how long that immunity lasts with natural infection. Experts are suggesting that if you've had COVID-19 disease, that you still be vaccinated, certainly with reasons, time limits as to when you can. We have to look at the history of vaccine acceptance of a person. Have they continually received vaccines that were on the CDC recommended schedule? And then we have to look at that, like I was talking about, the personal health literacy. Healthy People 2030 updated their health literacy definition to include one pertaining to personal health literacy, which is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves or others. We need to be a part of empowering adults to have personal health literacy skills surrounding COVID-19 vaccine information. Literacy skills to make vaccination decisions for their children when a COVID-19 vaccine becomes available for them. Healthy People 2030 also added an organizational literacy term that I'll discuss later. How about interpersonal? So this is I can't see you all, but I know if you raise your hand, if you've encountered a family member, friend, or someone in your neighborhood or community that is vaccine hesitant. I wouldn't be a bit surprised if everybody raised their hand. It's important that we get to know who. Oh, thank you for raising your hands. I see that. It's important to find out who they're getting their information from. Are they getting COVID vaccine information from Facebook, Twitter, or Instagram? There's a lot of unregulated passing of misinformation on social media platforms that can potentially cause someone to become vaccine hesitant, putting anyone in their social network at an increased risk for a vaccine preventable disease. Certainly during the COVID-19 vaccine rollout, we need to make sure to monitor and report any disinformation and misinformation as quickly as we see it. Remember my story about the 2017 Minnesota measles outbreak disproportionately affecting Somali Americans? And in 2008, a Minnesota local TV news story highlighted Somali parent concerns about a disproportionate number of Somali children in special education programs. A Somali parent blamed it on the vaccines. Who can tell me what person Minnesota anti-vaccination groups reached out to meet with the Somali communities several times? You betcha. None other than Mr. Andrew Wakefield himself, the British former physician that was stripped of his license to practice medicine after a 1998 study falsely claimed a link between MMR vaccine and autism. The anti-vaccination networks, social networks, are very connected throughout the US, and Mr. Wakefield is still very active in spreading disinformation about the MMR vaccine. And certainly we've noticed I've noticed on social media and on TV that in Florida and California, we've seen groups of anti-vaccine protesting in front of the vaccination parking lot vaccination sites. Ms. Kearns will have some good information to share about how we should talk to people about vaccines. So another determinant of vaccine hesitancy could be institutional or organizational related. The presence of a primary care provider, the amount of healthcare provider COVID-19 disease and vaccine information that these organizations have, your healthcare provider has. I've noticed that some of the clinics that I go to, they are actually having just a link that talks about COVID disease and COVID vaccination. The other thing that is involved with institutional vaccine hesitancy is seeing our influential leaders get the vaccine. I know I was cheering when Dr. Fauci finally received his vaccine. And then certainly when President Biden and Vice President Harris did. And as well as seeing the support from influential leaders, certainly because the Black and African American community is suffering disproportionately with COVID-19 disease. The National Academy of Medicine has urged 60 of their Black health experts urged Black Americans to get vaccinated, hopefully creating a sense of vaccine acceptance versus vaccine hesitancy amongst Americans. But anti-vaccination groups have been protesting, as I said, at outdoor clinics in California and creating a visual presence of anti-vaccine misinformation. Communities, so community, how is determinants of vaccine hesitancy community? Certainly community members' vaccination experience, pain. I've noticed I'm in a Facebook group that has its COVID-19 healthcare workers. and everybody's been documenting after they've received the vaccine what the side effects or anything that they've experienced. Certainly, I see that some have been expressing a little bit of vaccine hesitance among healthcare colleagues about, oh, is it painful, or I don't want to, I don't know if I want to subject myself to this. So we have to be careful and mindful of vaccine hesitancy in the community that presents itself. The presence of disease and perceived risk in the community. This is a global pandemic of COVID-19 disease. It's very visible. The whole world is going through it. That certainly would be an area that could possibly influence vaccine hesitancy if others are saying, I'm not going to get it. I'm not going to get the vaccine. The other community are the religious, cultural, gender, and socioeconomic. Most religions do not prohibit vaccinations. There are some that do have a theological objection, such as the Church of Christ Scientists, but certainly most are not against vaccines. And geographic barriers are, in the words of Dr. Anthony Eiton, who spoke at a California Immunization Coalition, was a keynote speaker at one of our meetings, and he quoted, "Zip codes matter," and certainly it does matter when dealing with vaccine hesitancy. We got to look at policy, determinants of vaccine hesitancy policy, having health insurance. Certainly the ACA, currently the ACA as it stands, is no cost to any CDC recommended vaccines. And it has been stated that anybody who receives the COVID-19 vaccine will not have to pay for it either. Do we have a national vaccine plan? That certainly has been developing through the administrations. There's vaccination laws. Mandatory childhood vaccination laws have proliferated across the country after California's successful passing of mandatory school entry and child care facility attendance immunization laws, allowing only medical exemptions. Childhood immunizations increased after that law was passed, but was not met with 100% acceptance, because there were still people that were vaccine hesitant, and they chose to homeschool their children instead of getting vaccinations. My research shows parents reporting a disagreement with mandatory vaccine laws associated with more problems with concerns about vaccines. So we have to keep that in our pocket. All 50 states have legislation requiring specified vaccines for students. Exemptions vary from state to state. But currently, California, Mississippi, West Virginia, New York, and Maine are the only states that do not allow any type of non-medical exemptions, be it personal belief exemptions or religious exemptions. We have to look at historical pandemics, what policies might have influenced vaccine hesitancy in the 2009 H1N1 pandemic, communication through social media platforms, who should be delivering pandemic vaccination information, doesn't matter. So that's, in a nutshell, the many determinants of vaccine hesitancy that we have to keep our eyes out for. It's not a one-size-fits-all with vaccine hesitancy. The SAGE working, as I stated before, the SAGE working group on vaccine hesitancy discusses diagnosing the roots or determinants of vaccine hesitancy in each specific setting, or for purposes of this webinar, like I stated, at different levels at the SEM model. And it's fundamental to the development of appropriate and targeted interventions to encourage vaccine acceptance. I guess Madam Curie is the underpinning thought of what I think of when I think of vaccine hesitancy. I hope this vaccine hesitancy brief overview, I unpacked so much information for you all, but I hope the overview just shows you how complex determinants of vaccine hesitancy are, so we together can target and tailor our conversations and interventions with those who are vaccine hesitant to help them better understand the importance of immunization against vaccine preventable diseases. In turn, may our actions to help better understand the determinants of their vaccine hesitancy, and that they may fear that they and we may fear less when it's our turn to get the COVID vaccine. And now Ms. Kearns will tell us how to have some vaccine conversations. Thank you for listening, everybody. Be safe, everyone, and stay warm if you're in Minnesota. Thank you for your time.
Hi, thank you, Dr. Ferris. Let me start sharing my screen. Okay, well, hello and thank you for allowing me to be part of this opportunity tonight. As Dr. Fry-Bowers said, my doctoral project has focused on using the psychotherapeutic approach of motivational interviewing to address vaccine hesitancy. I'm grateful to be able to tie in some of my work with our current topic regarding the COVID-19 vaccines and offer a psychological perspective to the challenges that we are facing. Just very briefly, my objectives, they're very simple. We'll talk a little bit about the challenges of vaccine confidence, some techniques of Socratic questioning, motivational interviewing, and some advocacy and behavioral modeling that we can do. So the challenges, we've already talked about some of the reasons people lack confidence in these vaccines. It's important to consider the cultural context in which the issue of vaccine hesitancy exists. In 2020, a correlational study that developed a questionnaire exploring collectivism and individualism that was published by the British Journal of Social Psychology, a positive correlation was found between collectivism and adherence to social distancing, and following other government recommendations to prevent the spread of COVID-19. It's really interesting that we're already seeing a lot of studies coming out about this topic. Previously, when I was just studying basic vaccine hesitancy and motivational interviewing, there was a very slim picking, and now there's a lot of stuff coming out, which is really exciting in general for vaccine hesitancy. Adherence to the social contract is of great importance during the global pandemic, and a collective culture is more likely to respond accordingly. Conversely, individualistic cultures who place great value on autonomy are less likely to make the individual sacrifices that prevent the spread of COVID. And not surprisingly, other negative traits associated with individualism are feelings of powerlessness and a tendency towards beliefs in conspiracy theories. The researchers in this study describe powerlessness as the sense of being unable to make a meaningful impact on important issues. Relating to vaccine confidence, in another 2014 study by some of the same researchers in the one that I was just mentioning, they found powerlessness was a mediating factor between conspiracy beliefs and low vaccine intention. Conspiracy theories obviously play an important role in lower vaccine confidence. The belief in conspiracies is related to narcissism, among other undesirable personality traits. I don't think that we would find that too surprising. It's also important to understand the paradox that the stronger and more certain a person feels about a belief, the less likely they are to be swayed otherwise. So in a 2018 study out of the University of Queensland, a survey on vaccine attitudes spanning 24 nations identified attitude roots that these beliefs stem from. Essentially, throwing data at the already anti-vax person is more likely to set their beliefs more firmly against vaccines. So that's just such a huge challenge when we really think about why can't they just listen to the data and change their mind. Of course, we can't ignore the settings in which all of these beliefs are propagated. Social media and the 24-hour news cycle form this echo chamber where people begin feeling a strong sense of identity around their beliefs, creating tribalism and further division rather than individualism, as we were talking about here. So moving on past the challenges towards how we can start talking and changing the discourse around how we're talking about vaccines. So this is kind of more my wheelhouse and what I've been working on with my capstone project. motivational interviewing and Socratic questioning, they absolutely can be effective at improving vaccination rates. This study from 2019 out of Canada, where just in a postpartum unit, they found that using motivational interviewing to talk to mothers about vaccinating their infants has been very effective. There are, like I said earlier, there aren't a lot of really solid studies yet, but things are coming out this past year because of what we're facing on a global scale. So I wanted to talk a little bit about motivational interviewing, and Socratic questioning is part of what motivational interviewing is. It is a psychotherapeutic approach that is used and has been very effective to talk to patients with substance use issues, among other mental health issues. It incorporates things like open-ended questions, using reflection to kind of dig deep into the values and what's driving people to make their choices and their behaviors. The spirit of MI is empathy, unconditional positive regard, and active listening. And I wanted to just say also, we take caution. My project was in the context of being a provider, talking to a patient about, vaccine hesitancy. When we're talking to our friends or coworkers or family members or other acquaintances, we do need to have, we can't take the motivational interviewing approach completely, but we can use some of these principles like empathy, positive regard, and active listening to address these issues. And because the good intention to use those techniques could be misconstrued as you're being demeaning to me or whatever. So we do have to, come in with an open mind when we're talking to these people. Okay. So another way that we need to think about changing the discourse is more kind of on the systemic level. Dr. Ferris was talking a little bit about, like the policy changes that we need to make, and what kind of I'm gearing more towards is like the messaging and the systemic approaches that we need to take societally. Came across 2 studies that looked into how a perceived risk is influenced by how information is presented. Specifically, if information is presented with a more moderate lean, not a glowing, review of how the vaccine is, and certainly if it's not terrible, people are more likely to have confidence that they have been, they have like more realistic expectations towards the vaccine. So it really is talking about being honest about, okay, it's the second dose of the Moderna. I might need to plan on not being at work tomorrow because it might make me really tired. It might give me some flu-like symptoms for a day or two. But being open about how there are some side effects, along with talking about what the risks of not having it are. I think just as healthcare providers, we are always thinking about how we are presenting an intervention, whether there's, what the risks are and what the benefits are, and weighing those and what's the best choice that you need to make. And so having that moderate approach of how you are talking about this is really important. And it has been shown to be very important. Tighter cultural orientation, i.e. collectivism, is associated with positive responses to the pandemic. That government efforts to improve compliance could therefore consider promoting a collectivist orientation amongst the general public. We kind of have already talked about that when we're talking about collectivism versus individualism, but this is really how we can gear towards, going towards the greater good, upholding like the values of the greater good versus kind of the fear that might be driving other people towards not getting it on an individual basis. And then interventions that focus on empowerment and those that address conspiracy theories and other forms of misinformation are therefore likely to improve people's engagement with behaviors that reduce the spread of COVID. So And then just this final piece, I wanted to read just 2 quotes from a really comprehensive article that I found that talks a lot about the ways that we can help, improve the spread of, prevention of the spread of COVID-19. Norms of pro-social behavior are more effective when coupled with expectation of social approval and modeled by in-group members who are central in social networks. So we, as leaders, we're alum, people look to us to say, what do you think of this? And modeling that we have some confidence in it definitely carries weight. Being a source of moral elevation, visibly displaying pro-social and selfless acts can prompt observers to also act with kindness and generosity themselves. I really liked that this spoke to that because it goes back to what I was talking about, motivational interviewing. Compassion and kindness are really important when we are genuinely asking people, what's going on with why you don't want to take the vaccine, what are your concerns, asking open-ended questions in a non-judgmental way has been proven to be very effective in getting a conversation started and eventually being able to give more valid information to somebody who might be believing information that's not really based in reality. I also found an interesting pre-bunking fake news game that this article talked about. It's actually a game that has been shown to what they call be an inoculation effect towards conspiracies and other alternative facts. So I think, if we could make that available for people, I think it could be a fun way for the conversation to get started about how we are discerning between what is fake news and what is a reliable source of information. And then finally, this last point, I think that I could talk about this for probably an hour, and I'll try to keep it short because I think that when we talk about the questions that were presented, I can give a little bit more detail, but taking conversations offline and practicing principles of MI. So when we live in echo chambers, when we're just responding on a thread on Facebook or on Reddit, or when we're constantly kind of just looking at the news all the time and looking for a bias, like a confirmation bias, that it really becomes, we're alienating ourselves from other people that might be thinking differently, and it makes us less able to talk to people that are thinking differently than we are. So allowing ourselves to be open and genuinely listening, using open-ended, non-judgmental questions and using reflection to restate what somebody's telling you in a non-judgmental way, all within that context of the spirit of motivational interviewing, which was empathy, unconditional positive regard. So there's also recently a New York Times article on January 31st. It was just a kind of a abbreviated version of, I believe he's a social worker, he might be a psychologist, who has just recently written a book on addressing vaccine hesitancy with motivational interviewing. But he gives a really cute example of how to talk to a family member about, he uses, I don't know if you're familiar with Harry Potter, but talking to a family member who might be a Voldemort supporter and you are not, and talking to them about, what are some of the benefits of you being a Voldemort supporter versus what are some of the things that you're afraid of, and really opening it up. And the last thing that I wanted to say about that this kind of leads into, motivational interviewing is not about just affirming everything that person says. It's not just about, oh, okay, I see that. Yeah, I see that you don't want to get a vaccine. I see that you're afraid. It's really digging into the whys and trying to navigate what's a reasonable response that aligns with that person's values. And so it's more complex, and that's why I don't want to focus entirely on that, but using the spirit of it, I think, is effective in how we can talk to, just generally anyone about vaccines, what we know about it, feeling confident ourselves about it, and being able to give that information non-judgmentally. So yeah, I am going to quit sharing my screen, or hold on, stay at home. I'm gonna offer my references because there are a few good articles, including that New York Times article in my reference list that I think are interesting. And I will go ahead and do that in the chat box if anyone's interested in looking at that. So thank you for your time, guys.
Thank you so much, Ms. Ball. I really appreciate your presentation. Gave us a lot of good ideas about how we can have these kind of conversations with our family, our friends, our coworkers. And so we just have a couple of minutes now. So rather than get into a really deep Q&A tonight, I invite you to join us tomorrow night, where we will have a lot more time to answer some questions, particularly the questions that were submitted before the webinar. And then we may have some time to take some live Q&A tomorrow night as well. We'll see how it goes. We have 2 presenters tomorrow night. But before, it looks like we've got maybe about 3 minutes or so before I hand it off back to Megan. And I just want to ask both of you, because I think this is something that probably comes up for a lot of us, whether we're a healthcare worker or not. And that is, how do we respond to somebody, be it another healthcare worker, or be it a colleague or a friend or a family member, when there is misinformation or disinformation being offered? We're right there in the situation. How best do we step in and say, maybe try to interrupt that conversation? Since we just finished with you, Ms. Ball, I'll go right back to you and see if you have anything to offer us in that regard.
I do. I'm a nurse, and my organization that I work for actually, recently has offered vaccinations for all of us. And I was part of a conversation at work, actually, where there were several naysayers of, oh, I don't think I should get it. I don't really trust it. I think that it's really important to have the knowledge of what it is. So I actually said, here's the research article. It's actually readily available to read. We're nurses, we can read this and understand it. And I've read it. I kind of gave them a synopsis of what I read and talked about, for everyone, we have to weigh the risks and benefits. And this is how I shared my personal experience of, why I decided that it was, the benefit of taking it was greater than the risk. And then asked them, what are your concerns, and really just asked them to talk without my prejudgment. So, and it seems to be pretty effective. So, yeah.
Dr. Ferris, do you have anything to add? How do we confront misinformation or disinformation about the vaccine? Oh, you're on mute.
I think certainly that Olivia did a wonderful job about presenting, how to talk to others about it. The one thing that I can add is that I do is exactly what Olivia was talking about, is what are your concerns? And then I always reflect back to, where do you get your information? Where do you get your information from? Just to kind of check and see, are they getting it from valid and reliable sources? It's important that that if they're not getting it from a valid and reliable source, that we direct them to a source that's valid and reliable with information, so that they don't become vaccine hesitant based on fake news or a misinformation area.
So to that end, that's a great segue to, we will be providing additional resources for all of those who have registered for the vaccine hesitancy webinars. So please stay tuned. We'll be sending out that information following the completion of the webinars tomorrow. But I see we're at 2 minutes to the hour. We really want to thank you for your time tonight, and we really invite you to join us again tomorrow night, where we will be addressing the concerns of special populations. We have some great presenters, Dr. Pedro Colio and Dr. Dorothy Ford. And now I'm going to hand it right back off to Megan. And again, we hope to see you tomorrow night. Thank you for your time and attention today.
Great, thank you so much, Dr. Fry-Bowers. Well, as she mentioned, that about wraps up our time for today. But once again, I want to thank you, extend a thank you to the Hahn School of Nursing and Health Sciences for your partnership on today's event, and to Dr. Eileen Fry-Bowers, Dr. Catherine Ferris, and Olivia Kearns for taking the time to answer questions about the vaccine, why it matters, and to better understand the terrible disease and what the USD community can do to help stop the spread. Thank you to all alumni, students, parents, and friends of USD who joined us for today's event. We hope you found today's webinar to be interesting and informative, and we hope that you will join us for tomorrow night's session that focuses on the COVID vaccine in relation to specific populations. As Dr. Fry-Bowers also mentioned, we will have some allotted time for a Q&A and to address more questions. So we really encourage you all to join us for tomorrow night's session. It is also at 5 p.m. Pacific Standard Time, and we will send the link to that here shortly. To register and to view other programs that the Alumni Association provides, such as our Tiny Toreros podcast, virtual events for affinity and regional clubs, and Hire USD, a campaign where we encourage toreros to hire toreros, please visit alumni.sandiego.edu. And once again, all of the resources, links to future events, other options that you have to be involved with the Alumni Association will come to you shortly in a wrap-up email for both of these two panels and webinars. So once again, thank you for everyone who logged in, and we hope to see you at tomorrow's event, and if not, at another USD event soon. Take care, everyone.